This session is going to focus on understanding how to use tangible tools and resources when engaging stakeholders in selecting outcome measures. Lisa Juckett is Associate Professor in Occupational Therapy in the School of Health and Rehabilitation Sciences at The Ohio State University. Her research bridges the gap between empirical discoveries and the use of these discoveries in real-world practice settings that primarily serve older adult populations. Her work has been funded by entities such as NIH, AOTF, and the Administration for Community Living and the National Science Foundation, and she is actively involved in local and national service initiatives to improve health outcomes of vulnerable aging community. So now I'm going to hand this over to Lisa. Okay, and there you are. There's the mouse to advance the slide.
Great. Hi, everyone. Good morning. So as Linda mentioned, this session here, session A, we get to kick it off, is all about selecting patient-centered outcome measures. And so we're joined by 4 very talented investigators here, and I would love to introduce them all to you. So first off, and when I think, I should say this first, when I think of patient-centered anything, I think of PCORI. And so we're very lucky to have PCORI represented here today. Dr. Erin Holve serves as Chief Officer of Research Infrastructure and Innovation at PCORI, the Patient-Centered Outcomes Research Institute. And in this role, Dr. Holve executes strategies, there we go, to advance patient-centered comparative clinical effectiveness research methods and study designs, develops and leads a team that will deliver on PCORI's vision of a large, efficient, and patient-centered clinical data research infrastructure, and lead strategies to advance training and knowledge for patient-centered outcomes research. Dr. Holve has more than 20 years of experience in health policy and health services research and is a widely published and cited author of reports and peer-reviewed articles on health system design, health insurance access, as well as health IT. Dr. Holve holds a PhD in health services research from Johns Hopkins School of Public Health and master's degrees in public health and public policy from the University of California, Berkeley. And joining Dr. Holve is Dr. Nick Koscielniak, a program officer also at PCORI in research infrastructure and innovation. He manages a portfolio of research and infrastructure awards related to PCORNet, which is the National Patient-Centered Clinical Research Network. Dr. Koscielniak has studied clinical data infrastructures and implementation science in support of a national integrated learning health system and supports efforts in this space at PCORI. Dr. Koscielniak received his PhD in Health Infrastructures and Learning Systems from the University of Michigan in the Department of Learning Health Sciences, where he trained as an implementation science and studied determinants of clinical data practices and missingness in health systems. Dr. Koscielniak is also a licensed and registered occupational therapist, holds a bachelor's degree in anthropology from the University of Missouri, and 2 master's degrees, one in OT and one in public health from Washington University in St. Louis. So after we'll hear from PCORI, we'll then hear from Dr. Chloe Slocum, a practicing spinal cord injury physician, associate chair for quality and assistant professor at Harvard Medical School's Department of Physical Medicine and Rehabilitation, and director of health policy at Mass General Brigham Spaulding Rehabilitation Network. Her clinical work centers on optimizing long-term health for individuals with paralysis, and her research is focused on assessing functional outcomes following rehabilitation, accessing high-quality primary and specialty care, and improving systems of healthcare delivery across the post-acute care continuum for individuals with disabilities. Dr. Slocum has published research on functional outcomes following traumatic spinal cord injury and has lectured nationally on topics ranging from spinal cord injury outcomes to health policy and payment reform to clinician well-being. And lastly, after Dr. Slocum will be Dr. Kalpakjian, an associate professor and associate chair for research in the Department of Physical Medicine and Rehabilitation at the University of Michigan Medical School. She is a biopsychosocial scientist with a clinical background in rehabilitation psychology and 30 years of experience of research and service to diverse populations of persons with disabilities. Dr. Kalpakjian is faculty co-lead of the University of Michigan PM&R Learning Health System, working collaboratively with diverse clinical teams to transform them into learning communities by evaluating their current practices, engaging in consensus building for changing, standardizing those practices, and selecting clinically relevant patient-reported outcome measures to complement clinical evaluation. So a very well-qualified team of speakers up here today. And I will now hand it over to Dr. Holve and Dr. Koscielniak. advance with it.
Nice. Perfect. Thank you so much. Well, good morning, everyone. It's a real pleasure to join you for what sounds like it's going to be a fantastic set of conversations and creative thinking about how to achieve a number of different ways of accessing and using data for the purposes of rehabilitation research. So as Lisa said, and thanks, Lisa, for that kind introduction, I'm Erin Holve. I'm PCORI's Chief Officer for Research Infrastructure and Innovation. And part of what that means is that I'm going to kind of expand the diopter here and talk to you all a little bit about some different ways of thinking about patient-centered measurement. And Nick and I are really here to give you sort of a sense of kind of the pipeline of funding opportunities and activities that PCORI is engaged in that could support your research. So we're excited to hear your questions and find ways to really be responsive and give you a sense of how PCORI could support this work. Also want to acknowledge our colleague Megan Warren, who's here as well. And, the three of us really representing PCORI are happy to answer any questions about opportunities with PCORI. So Nick and I were talking about this the other day and figured, the best thing we can do in any particular group like this is to help connect some dots for a research community. And so that's really what we're going to do this morning. I'm going to talk first about, some aspects of PCORI's portfolio and give you sort of an overarching picture of how you can think about engaging with the Institute. And then he's really going to talk about some specific opportunities you may want to keep in mind, again, as you're thinking about ways to support the type of research that you're engaged in. And again, particularly sort of new ways of using data from some of these resources. So I'm going to really address PCORI's mission, vision, and research priorities to do some level setting. As Lisa said, I think there are a lot of folks who are familiar with PCORI, particularly our work in patient-centered research and engagement broadly, but may not have the best sense exactly sort of what we fund, how we fund, et cetera. And part of that is really talking a bit more about the portfolios in comparative clinical effectiveness research and the work we do there, and then how that connects to our focus, our strategic focus on accelerating progress towards an integrated learning health system. So again, for level setting purposes, I think as folks may be aware, PCORI was authorized in 2010 to do a couple of different things, really to be a independent nonprofit research institute. So we always like to emphasize PCORI is not a federal agency, though it is sometimes confused as one of the agencies, to fund studies that are designed to help people make better informed healthcare decisions. That's it, full stop. The information has to be useful to patients and communities, and it really originates and circles and cycles back to that point in all of our funding. And so to achieve that mission, our primary aim is to be a funder of patient-centered comparative clinical effectiveness research that, again, helps people make better informed decisions, and improve healthcare delivery and outcomes by producing the type of high integrity, evidence-based information that comes from research, again, that is guided by patients, caregivers, and the broader healthcare community. So how does that play out in terms of the actual portfolio? I like to be really direct about this because these are not just sort of philosophical criteria. They're actually the considerations that are used when an investigator submits a letter of intent to PCORI to start the pathway of pursuing funding. So again, first and foremost, all research activities that are proposed to PCORI must engage patients and other community members, stakeholders throughout the research process. And Nick's going to talk about this a little bit later when we talk more about PCORI's more recently released foundational expectations that really sort of spell out the components of engaging patients and other community members throughout the research process. Second of all, it has to be comparative, right? It has to compare at least two healthcare treatments, services, or practices. And again, there can be a mix of those and what PCORI is looking at. But this is not placebo-controlled trials, right? The third is it has to really focus on questions that are most important for patients and those caring for them. And the third is it has to aim to produce evidence that can be applied in practice settings. Now, there's a key consideration here that I realize is not on the slide, but I always think is exceptionally important in practice communities. And I think Nick's going to talk about some papers from, the rehabilitation research community to get at some of these issues, of effectiveness, right? So PCORI is funded to support research that supports effectiveness research. And what that means is every single, intervention or treatment, one of those comparators that I mentioned, actually has to have either an established base of efficacy, right? And I think, as you all know, the literature can sometimes be spotty on that front, or an investigator has to demonstrate that the treatment is in widespread use. And so those are important considerations to keep in mind. So again, I think I've already, covered most of this, but just want to reemphasize, as we always do, that there's a meaningful process of engagement that we're really looking to see, and that, we particularly will be looking for ways in which an investigator can demonstrate the development of research priorities through to dissemination and the uptake of findings, right? Because again, it's all about making sure that there's research that's going to inform practice and improve outcomes. And certainly engagement with communities, for example, as we're going to be talking about in this session, to select the most appropriate patient-centered measures that can be responsive to the communities of interest is critical. So I also want to make sure you all are aware that with PCORI's reauthorization in 2019, there was a substantial effort to go back and sort of revisit the initial framework and approach to research. And so that has generated these 5 ambitious long-term goals, the national priorities for health. 3 of them, I think are pretty much in sort of the warp and weave of what you would expect, right? Increasing evidence for existing interventions and emerging innovations in health. The second on enhancing infrastructure to accelerate patient-centered outcomes research. That's really the area that Nick and I spend most of our time in, the group that I have the privilege of leading. And then the third is advancing the science of dissemination, implementation, and health communication. All good stuff, right? Mom and apple pie. The 2 new ones that I really want to draw your attention to, because I think they do raise some thorny questions as well for how you make sure you've really got the best approaches to patient-centered measurement, are, in the equity space, right? Really focusing on how we're going to demonstrate that work that we're doing is actually achieving, not just accelerating or enhancing, but achieving health equity. And then very closely related to the topic of today's meeting is the focus on accelerating progress toward an integrated learning health system. And Nick and I spend a lot of time talking about what that means. And particularly, we're going to offer some challenges with respect to how you all think about doing your work. And again, particularly from that patient-centered measurement perspective, to really be a true learning system, right? We would probably argue that a learning health system is not a noun, it is a verb, right? It's the action of really figuring out how to do this work in a different way. And so that's where, we're really trying to make sure, as Nick will talk about in a second, that the infrastructure that exists is capable of really enhancing that type of acceleration towards a learning health system. So I just want to conclude my section by, again, offering some opportunities to frame your thinking about how all of these pieces fit together and where there are funding opportunities from PCORI that, may be useful to pursue. So these are some of the upcoming funding cycles for 2025 to bear in mind. And again, as I mentioned, PCORI has a letter of intent process through which folks are invited to submit a full application. And then sort of move through these cycles. And so what I have here on the far right are the letter of intent deadlines that apply to most all of these opportunities. So the next one that you can see coming up is January 14th. So again, Megan and Nick and I are happy to answer any questions you have about those. But I'll particularly draw your attention for the purposes of the meeting today and tomorrow to the not only the broad pragmatic studies program, which may be of interest, that really is sort of the general standing opportunity for CER studies that may be sort of smaller in scope, more at the $5 million range of funding up through $12 million and funding, for typically more of the pragmatic trials. But also because the focus again today is on measurement, really want to encourage you all to take a look at the methodology funding opportunity, which is offered every cycle. And there are, I think, some key areas there that may be of interest. I would just emphasize that with methods funding, we are not funding, for example, the development, validation, and testing of measures in a specific narrow area of focus, right? The methods have to be strategies that really truly improve or move in the direction of patient-centered measurement that can be applicable to a number of areas. But of course, the field of rehabilitation research is broad, and so there are ways that those opportunities could be applied more broadly there. And then the science of engagement is really looking at new ways to involve patient and other communities in the processes that we've been discussing. And then the other thing that I don't have on this slide that I should emphasize are our regular standing cycles related to community engagement and the Eugene Washington Award Program, among some others that may be of interest. So I think I'll pause there. But again, I just wanted to sort of set the stage really for the breadth of funding opportunities that PCORI has and how they could be tied to the enterprise and the work that you're all going to be discussing. And I will turn things over to Nick to talk a little bit more about infrastructure.
All right. Thanks, Erin. So I'm going to talk a little bit about the kind of refer back to the toolkit that Erin and I had included at the very beginning of these slides, and then kind of working our way through some of well, at least this section will focus on more of the components of a learning health system or integrated learning health system, and then we'll move into some of the resources that PCORI has to support the ability to do learning health systems related research. So as many of you know, there's a unique relationship between the concept of a learning health system and rehabilitation. So as a field, we are inherently patient-centered, striving to support those patients to achieve their rehab and participation goals and improving functional independence. So in recent studies and papers, though, this has really forced the field of rehab as well as the health system in general to grapple with how to actually improve infrastructure to build real learning health systems. This includes how we describe rehab interventions, such as the White study funded by PCORI, which I'll mention, which I'll talk a little bit about later. And this was actually mentioned in Jetty's editorial here, related to how those interventions are operationalized in research, how we collate those interventions and create a systematic approach to managing those. So in terms of the capacity of data and research infrastructure, this is also mentioned in much of Friedman's work related to socio-technical infrastructure for learning health systems. So some of the ability to do the learning health system related activities requires the evaluating the capacity of the existing infrastructure to support the types of continuous learning activities that Friedman and colleagues have championed, to really make the meaningful and scalable changes to patient care and outcomes. So some of the work that I completed a few years ago with Dr. Friedman demonstrated that even something like developing physical function computable phenotypes, which are important for being able to then identify patients of interest for recruitment and studies, is a significant issue and relies on significant data or significant socio-technical infrastructure or socio-technical infrastructure like missingness of structured data. And so there's a misalignment to some extent between rehab practice to some extent and data documentation. And this has a tremendous impact on being able to even measure patient-centered outcomes in real-world settings. So really mobilizing the rehab learning health system also requires the training of research scientists, the research workforce, to be able to take a systems level approach, and within embedding these folks within the clinical care delivery settings to address the health and rehabilitation system problems. So given this, also a recent paper by Bickenbach, I'm not sure if any of you have seen this, has really made me question whether there is a distinction between the concept of a learning health system and a learning rehab system, which may require obviously a more robust infrastructure beyond the traditional medical model. Now, that's not the topic of today. So, I assume all of us are here, or all of us here are really actually familiar with some form of learning health systems. However, there are multiple definitions of learning health systems in the public domain. Well, most of us, most widely accepted is the National Academy's definition, which is included here, that was drafted in 2007. Other funders and scientists in the field have actually described various versions of a cycle of learning, some with many components and moving parts, such as Friedman's approach, and then also more reductionist approaches that AHRQ and NIH may take. Now, just yesterday, I also came across a newly funded NIH network for genomic-enabled learning health systems, which describe learning health systems as a type of clinical practice that bridges research and patient care. So think about that. It's now become a type of clinical practice. It's gone from this theoretical approach for maybe how a system may operate to leverage research to now something referred to as a clinical practice. Now, talk about reductionist, right? But what is important here is the necessary investment to actually build network infrastructure to be activated for learning health system research and practice. So this consideration between what may be learning health system practice versus research also calls into question, where is a learning health system? Given that many health systems have begun to self-designate as a learning health system, health systems have designated, self-designated as a learning health system, or individual research teams referring to having built a learning health system for some sort of key purpose or key population or intervention. Now, while colleagues of mine may argue about the concept of learning health systems, whether it's real or it's theoretical, it doesn't really mean the mere concept hasn't had a tremendous impact on or tremendous influence on how clinical research and practice have actually evolved since the 2007 NAM report. And in addition to the scaling of EHRs. Now, given this question about what constitutes a learning health system, Erin and I have actually worked on refining a nomenclature for learning health systems over the past couple of years, which really spans a health system mission for learning all the way to an integrated national patient-centered learning health system. Now, this nomenclature really has forced us to think about how we may invest in the operationalization of learning health systems and where the various types of learning health systems may occur. While I won't go into significant detail here, the main takeaway is that the different concepts and models of learning health systems really result in heterogeneity of the implementations and actions. And so these learning health system types are really present in federal, academic, and health system settings. And so one of the things that I also wanted to mention kind of ties into this is that there are many different approaches to the way that people consider learning health systems, the way that we define learning health systems, and as I mentioned, there's learning health system types that are present in the federal, academic, and health system settings, as demonstrated by this table here, which is really focused on thinking about the dimensions of infrastructure and the extent that many of these interpretations of a learning health system include various different dimensions, some more than others. There we go. So building on the previous nomenclature, another way to really think about learning health systems is also considering that there's, given the balkanization and the previous slides actually on those two areas and PCORI's national priority for health to accelerate progress toward the learning health system, PCORI actually brought together representatives from diverse entities across the health data ecosystem, which included health data communities, networks, and federal agencies to really identify a core health data services and identify potential opportunities for collaboration needed to accelerate progress towards an integrated learning health system. So this learning health system data services convening was held at PCORI in October of 2023. There were about 40 folks that were invited to participate in that. And the convening really focused on four primary goals that are described here, but the overarching goal was really to organize collaboration to advance data services that rapidly learn about and improve the health and healthcare of patients. So in addition to the conceptual work and the convening, PCORI is also funded or is funding several rehabilitation focused patient-centered CER and methods projects. So we selected several for the group to refer to, and the links are actually provided to the PCORI project pages are provided here. These projects, while not really focused on infrastructure or per se or specify the learning health system, actually reflect the different types of projects that PCORI is funding in rehab, which really build the learning health system capacity. Notably, the project by White was a methods project, which Dr. Jetty had referred to in his editorial in opening the black box of rehab interventions that developed that rehab treatment specification system. So other studies included here are really focused on comparing different treatment interventions or different treatment approaches for improving our understanding of effective or comparative effectiveness of rehab interventions. So moving on to the kind of the back to the toolkit. So we've talked about the three areas on the left, and now what we're going to do is talk about more of the resources that PCORI has in in order to support an integrated patient-centered learning health system. In terms of the next phase, so of this, as Erin mentioned, there are 6 foundational expectations for partnership that were recently released by PCORI to really engage the research community and establish these key activities that are necessary for partnership and PCORI-funded projects. Now, these are considered the building blocks for meaningful, effective, and sustainable engagement with patients, communities, and other partners in research. And these expectations really build on the recent evidence that PCORI and PCORI awardees' experiences with engagement and provide a structured way for project teams to approach and tailor engagement to achieve project goals. So PCORI and AHRQ also recently funded or awarded funding to 16 learning health system embedded scientist training centers through a P30 mechanism. I won't go into detail about that, but many of you are probably aware of these different centers. One obviously related to rehabilitation. In terms of methods program, these are, as Erin mentioned, PCORI has a methods portfolio. These are focused on improving the conduct of patient-centered CER, or methods to improve the conduct of patient-centered CER. The portfolio is fairly robust. There's currently 41, or as of February 2024, there's 41 methods projects in progress. And so these projects are the opportunities for these projects include $750K in direct cost up to 36 months. They require a letter of intent, and they are offered in standard, they're standing funding opportunities that occur at each of the 3 funding cycles that PCORI has each year. There are 4 different areas that are 4 different priority areas for these methods awards, which includes improving study design, methods to support data research networks, methods to improve the use of AI and machine learning in clinical research, as well as methods related to ethical and human subjects research or human subject protection. One of the things I wanted to mention is, so as is consistent with PCORI's authorizing law, there's a methodology committee that actually develops and updates the methodological standards for patient-centered CER. There are several, I think there are 16 members on the methodology committee, 2 of which are designees from AHRQ and NIH. They develop method standards. There are 17 topics that comprise 67 methodology standards to support that PCORI-funded projects must comply with. One additional item too on the methods, there's a current call for nominations for the methodology committee or to be appointed to the methodology committee. There are several areas that were included here related to that are of particular interest for the methodology committee. But I will say that there's a new approach for this cycle, which is applicants are allowed to self-nominate and not rely on someone else to nominate. But the call to nominate is open. So if you know of any folks, or if any of you are interested, please take an interest in going and self-nominating. Something happened. Wait. All right, in addition, so PCORI is a data management policy, management and data sharing policy. This is actually directly relates to the depositing data in a data repository known as PCORI, or the Patient-Centered Outcomes Data Repository. And this is really meant to facilitate the data sharing. In terms of areas of interest, there are not areas of interest, but all or certain PCORI funded studies are required to deposit data from their CER studies. The purpose of this is really to facilitate the reproduction of analyses to increase the integrity of PCORI funded CER, as well as building on the study findings or integrating data from multiple studies to generate new evidence. One last item for these resources is the PCORI Health System Implementation Initiative. I won't go into detail on this, but there are 42 health systems that participate in this. There's a focus on capacity building projects as the first phase, and then a second phase, which is actually funding those groups to actually implement the new evidence in several eligible evidence domains. The last area that I want to talk about briefly is PCORNet. I say briefly, but I could talk all day about PCORNet. It's what I do. It's what I eat, breathe, sleep. And so PCORNet was established, or not established, but PCORNet was authorized for by the board by the PCORI board in 2014. And it was really developed as this catalyst for doing research differently. That really focuses on embedding the patient partnership and the community engagement in all components of network activities, and really being able to enhance the capacity to conduct research with real-world data, such as EHR data, claims data, and the like. And the goal is really to build a reusable infrastructure and capacity for this continuous improvement. So PCORNet by the numbers, PCORNet's been around since 2014. It's a 10-year anniversary this year. Since 2020, there have been over 45 national scale PCORNet studies, which include 2 or more or sites from 2 or more clinical research networks. There are 8 clinical research networks that participate. From a patient population standpoint, there are 47 million patients with unique or with encounters annually that are seen at PCORNet sites. So it's a pretty robust network. There are over 13,000 clinical sites of care that kind of comprise the 78 different PCORNet sites. So this slide here is actually meant to provide you with a kind of the magnitude of CRN sites. So there, as I said, there's 8 clinical research networks, 78 sites. The highlighted sites are actually the overlap with the CTSA awards. So these are all both sites that have a CTSI as well as a ARIA PCORNet site itself. So PCORNet also has a coordinating center. There are 3 institutions that currently help manage the coordinating center for PCORNet. That's the Children's Hospital of Philadelphia, Vanderbilt, as well as Duke University. As I mentioned, too, so PCORNet is a national scale infrastructure, and there are a number of resources to really support the ability to do national scale research with the 8 clinical research networks and over 13,000 clinical sites of care. The number here that was included on the bottom is over 34 million. That's old. It's now 47 million or over 47 million. So just keep a note of that. In addition, we also recently added 16 new sites in August of 2023. So the last slide actually included those additional sites. And so that really increased the patient population and the reach of PCORNet itself. But the coordinating center that I wanted to kind of bring to your attention, so this slide brings the attention the coordinating center, which is really focused on these 3 different areas of the governance and research readiness, as well as engagement and public awareness of the network, and then also data services. And so when I say data services, I'm talking about managing a PCORNet common data model, which is a standard, an approach in which the network has agreed, all network sites have agreed to map their EHR data to a common standard, similar to OMOP if you all are aware of OMOP. But these three areas are really important for ensuring that the network is engaged and supported for the ability to do large-scale national research. As I mentioned, the PCORNet Common Data Model, it includes a number of different tables. There are some that are research ready and others that are ready for research, but they require more elbow grease to really improve the data quality themselves. But the ones on the left here are those that are known to be extremely ready for research, and the ones on the right are the ones that are still evolving. I will say too that there are recent efforts to improve or expand the PCORNet Common Data Model in areas such as social determinants of health, patient-reported outcomes, as well as improving the capacity to do geocoding across the network in order to link to databases such as the AHRQ Social Determinants of Health database, which actually includes a number of community level and population level data or measures, I guess. So one of the other things that I wanted to kind of put on everyone's radar is, when we talk about PCORNet, most of the questions that I get is, well, what's in PCORNet? And so when I over the last couple of years, or over the last year at least, Erin and I have really talked about how do we make more of the data available, right? How do we increase the public awareness of the data resources available in PCORNet? So in alignment with several of PCORI priority areas, such as intellectual developmental disabilities, maternal morbidity and mortality, as well as a recent topic theme that PCORI had related to the pediatric population, PCORI has actually initiated several queries in these areas to really kind of open the hood or pop the hood of PCORNet so that folks can really understand and the different cohorts of patients that are represented by the network. Now, these are only a small few of the many different types of questions that people can ask to really understand the different populations represented by PCORNet. Recently, the pediatric population was that query report was posted, so it's pretty fresh. So I encourage you all to look at that. Yes, so all of these query reports include the code sets that were used to develop the specific cohorts of interest. So those are referred to as phenotypes to at least Erin and I and maybe many others. But all those code sets are included so that there's a level of or ability to replicate those or improve on the actual code sets themselves. Other opportunities that I wanted to put on folks' radar is the BPS or the Broad Pragmatic Studies Category 3 opportunity. This is a standing funding opportunity. There are three categories that are included in the PCORI Broad Pragmatic Studies opportunity. The third category is for PCORNet studies. These are large studies up to $12 million in cost for up to 5 years. And they're really, the studies must address PCORI's national priorities for health. As I mentioned before, PCORNet studies must include sites from 2 or more clinical research networks. And also there's a requirement to share study progress, performance metrics such as days to IRB, the number of patients first enrolled, and those are shared monthly. There's also the sharing of best practices that are identified during the course of the study. And so sharing those with the PCORNet Steering Committee and as well as other venues that the network has, such as best practice sharing sessions and the like. There's also a requirement to use PCORNet resources to improve the efficiency of the studies themselves and the conduct of the study. The PCORNet Common Data Model is not required, it's encouraged, but there are other resources that can be leveraged as well for PCORNet studies, including single IRB and other engagement resources. One additional item too, in thinking about, selecting patient-centered outcomes, which I know is the topic of this, and I know we've kind of veered off a little bit, but I think it's really important to at least put all of this stuff on the radar, is the engagement activities that we've done with the network related to developing roadmaps for being able to accelerate progress in the conduct of IDD using PCORNet, as well as maternal mortality and morbidity. And so, one of the ways that, PCORI is really thinking about the way that PCORNet can support learning health systems is really starting with the patients, the researchers, engaging them in really understanding how can the infrastructure be improved to actually address these important questions of interest. And so these activities, both the work groups that were established to build these two roadmaps, were really focused on the ability to identify the questions of interest and then understand the extent that the data resources or the resources provided by PCORNet beyond data are actually suitable for the conduct of these research activities in these two areas. Now, that doesn't mean that the network can't be used for these. It means that that opportunities like the PCORNet BPS, which identifies areas to build additional infrastructure, can be used to address some of these areas that are identified, in addition to being able to improve how we answer the questions that are of priority to these two fields of research. So I encourage you all to refer to these, to read these, to really understand both PCORNet itself more in depth, as well as understand the questions that are important to these groups, and then also consider how the questions that you have may be suitable or addressed using the PCORNet infrastructure. So if you're interested in connecting with the network and receiving a quarterly newsletter or receiving multiple emails from the network, feel free to scan the QR code here. Also refer to the PCORNet website as well as other social media. With that, I think we're happy to answer any questions after Claire and Chloe. But here's our contact information if anyone is interested. Thanks.
Hi, everybody. Thank you so much. It's really an honor to be here. And that was an amazing presentation. I'm going to take it down just a little bit, talk to you about our experience at Spaulding in terms of balancing stakeholder needs and selecting and collecting outcome measures. A project that we did looking at social determinants of health and health-related social needs, predominantly in the inpatient setting. So what I'll be doing, oops, sorry, my notes screen. Okay, so I'll be talking a little about identifying stakeholders. So who are the stakeholders when we're collecting patient-centered outcome measures? Obviously, the patient is there sort of in the term. And a little bit of background about me. One of the reasons I got into rehabilitation is actually because when I was in medical school, rehabilitation was sort of a field where it was about getting people back to doing meaningful things outside the four walls of the hospital. And I was really attracted to that because the definition of success in that case is sort of necessarily heterogeneous and depends on what is meaningful for you or for me or for our family members, and sort of that richness in terms of being able to achieve that and being able to work in a team towards that goal. And so it mattered that we got people's blood pressure under control, and it mattered that we were achieving sort of uniform health outcomes in a certain sense, but taking that next step beyond that to where people are really thriving in their communities was what attracted me to it. So hopefully that resonates a little bit with you. But we want to sort of think about how we're mapping clinical processes when we are collecting patient-centered outcome measures and acting on them with an eye towards inclusivity, contingencies, as well as dynamic change within health systems. We're going to talk a little bit about establishing measure quality and suitability for a particular clinical context. Considering things like reliability, validity, feasibility, usability, and then sort of any competing measures. Trade-offs for patient-centered outcome measures in terms of thinking about likelihood, short and long-term impact, and then use across diverse clinical settings. Again, coming back to the fact that we're practicing in so many different settings. And sometimes if we're trying to use a single measure, thinking about what that means in a particular clinical setting can be different. It can be different for different populations. And then different strategies to help address stakeholder needs in terms of thinking about specific assets and constraints in a particular setting, engaging across disciplines, and then really gathering community perspectives, which I think is important. Okay, so a little bit about our context. So Spaulding is a sort of regional network of post-acute care providers. For the purposes of this work, we worked with our inpatient rehabilitation facilities, of which there are 2, and we have about 3,000 inpatient admissions between these 2 facilities, largely patients in Eastern Massachusetts and New England. We were looking at screening for health-related social needs. We decided on this, so there's a number of different terms. ASPE uses social risk factors, which at sort of a patient level, I think has more of a pejorative connotation. Not everybody's sort of, where risk factor can sound negative on the face of it, although, as a policy person, if I put on a sort of health economics hat, it could be positive risk factor, could be negative risk factor. But when sort of consumers are hearing that, I think we decided health-related social needs was what we wanted to focus on. So we'll talk a little bit about how we developed an intervention to screen for that, and the process by which we went through thinking about process improvement clinically, and then arriving at some of the next steps in terms of implementing this in a meaningful way. So let me see. It is okay. So when we identified stakeholders, we looked at inpatient in terms of collecting these, and we found that we were only collecting health-related social needs on our inpatients anywhere between 30 to 100% of the time at our Boston site. It was quite variable. So 100, and sort of led us to believe this is not a very standardized process. Even though the tools are sort of had been built into the electronic medical record, they were there, they were accessible by frontline providers, mostly. We'll put an asterisk in that and come back to it. And so they existed, but at our Cape Cod site, they were doing it over 90% of the time. So we thought to ourselves, what is going on between those 2 sites? And we could sort of hypothesize about a number of different things. At Cape Cod, they had a smaller team. They also had a smaller census, and the team had worked together for a very long time. And so they had sort of collectively agreed to implement something and then had done it relatively successfully. And there were fewer roles. So there were sort of people who had combined roles, people who were at admissions, people who were in case management, people who had been trained as nurses, and then it'd be sort of all one person. And that person would have sort of a very rich clinical background, and they were able to work together effectively. In Boston, we had a lot of people who were very well-meaning and very interested, but we had a larger census, we had a more heterogeneous clinical population, and we had people who sort of had been in their roles for different periods of time, and maybe floating across different units. So while they were working with the same team in terms of their specific discipline, they might be sort of geographically moving to different parts of the hospital, and they might be working with different clinical teams in terms of the other interdisciplinary team members that they were working with. And so when we started to map this process, it started to look very messy for our Boston site. And there were a lot of sort of, when we did our flow sheet, there were a lot of stars in terms of things that were unknown in Boston that, we spoke to our colleagues at the Cape. They were like, oh yeah, well, that's how we do this. And there was sort of a simple explanation for it. And so we began to uncover different stakeholders, and sort of more varied stakeholders in this. The other thing I'll mention too is that when we began to map this, we went and we sort of talked to everybody in the hospital. We did a sort of a grand listening tour of this. And one of the encouraging things was that nobody said, this is unimportant, you shouldn't be collecting this data. Everybody sort of very thoughtfully said, this is really important data. It is important to know that our patients with stroke who may live south of Boston are struggling with food insecurity. it is important to know that our patients who live north of Boston, who have a spinal cord injury, may be struggling with transportation access. It's important to know housing constraints for our folks that are going home from rehabilitation to Vermont, and what the resources look like in that community. So everybody thought that these things were very important to collect. The question was how to collect them and who should be collecting them, right? So we have this tool that exists within the electronic medical record, that in theory, everyone can access. But not everybody, thought like, well, I am the specific role group for that. So our admissions colleague said, gee, this is really important to collect, but we don't think we should be asking it when people are being admitted and we're going through their insurance, because it's the optics of it seem like there is a financial screen, and we don't like that it's so closely tied to that. And so we feel like it's sort of clinically important, but inappropriate at this particular time. We had other colleagues, not at our rehabilitation facilities, but at our long-term care hospital, who said, if somebody's coming in on an event, it feels a little premature to throw this at somebody or their caregiver, within 24 hours of admission, even if it's by a clinical team that's well-meaning. And so we had a lot of different feedback from that. The other thing I will say, this is a little bit small on the screen, but it's a Shirley Chisholm quote, which I thought was appropriate for DC, which is, if they don't give you a seat at the table, bring a folding chair. So we had several people that sort of showed up, and we wanted to get as many folding chairs as we could with this, because we found in the process of this that certain disciplines didn't have access to the information. We had thought it was accessible and it was visible to everyone. But for instance, our colleagues from dietary and nutrition couldn't see the data and they couldn't enter the data. And they were very enthusiastic about saying, if I knew this when somebody was admitted, the way that I plan my interventions and the way that I counsel my patients would be different. And so we were able to advocate for that within our clinical process improvement project, in terms of, thinking who needs access to this and who could sort of be meaningful at the point of care if they had this, or, even in a, not ultimately standardizing the process, but in a stewardship model. So if we think about this data like allergies, if a nurse sees that allergies sort of are empty in the chart, they can enter them. If a dietitian saw that this was blank in the chart, they could potentially enter them by knowing that it was there and having access to it. Okay, so talk a little bit about this. When we think about measure quality and suitability, there is sort of a balance between how detailed we are. And I think one of the things I will mention in terms of our existing tools is that they tend to be retrospective. And in rehabilitation, inpatient rehabilitation, we're often dealing with people who have new impairments. And so the tools that we use to collect social determinants of health and health-related social needs tend to be retrospective. And so they ask about, have you had transportation difficulties within the past 6 months? And so when we've audited our internal data, we found that on the inpatient side, the people who are being screened tend to answer that in the affirmative less than 5% of the time for transportation difficulties, which is one of our most successful measures because it is tied to payment within CMS. And that to me is sort of a red flag in terms of how suitable the measure is. Now it's the one that we have and it's widely used. And again, it's tied to sort of payment incentives. But are we really asking the right question if we ask somebody with a new spinal cord injury, have you had transportation difficulty within the past 6 months versus, do you anticipate having transportation difficulties? It's a little bit different. And the question is, arguably one may be more meaningful in terms of planning for somebody and how they're going to interact and reintegrate into the community after their inpatient rehabilitation stay. Okay, so we'll talk a little bit about trade-offs for outcome measures. When we think about outcome measures, there's sort of this paradox in terms of, we can have something that's super specific for a certain population. So I put like our Cannondale bike over here. And I'm not a biker, but like a sort of a top of the line measure that's like very specific. And it can work wonderfully for a certain population. And it can work wonderfully in certain narrow settings. And then we can have something that's sort of clunky and it's so general that it's not terribly meaningful over here on the right side. And so what we're aiming for, I think when we're collecting outcome measures optimally, is something that can translate across settings, like a bike share, where it can be used by a wide number of people. It's easy to access, and you sort of hop on and you go. And so I think that's what we really want. And it can be difficult when we're engaging with stakeholders sometimes to negotiate this because we'll talk a little bit later. There's not only a heterogeneity of outcomes, but there's a heterogeneity in terms of terminology and tools that we have. I think we can be inspired. I think in rehab, we have a lot of different examples where we're sort of really fluent in terms of how we collaborate across disciplines, and we can get creative. And so this is a sort of just showing us, in terms of we're thinking about a barrier, we're thinking about how to solve something. We have the tools to do this and to think about it in a little bit of a better way so that it can be both specific to populations that we want to include, and also broad enough to be valid and reliable for a more general population. Okay. So when we think about strategies to balance stakeholder needs, like I said with our listening tour, we wanted to engage everyone. So we wanted to engage patients and community members. So we met with our Patient and Family Advisory Council, which is something we're legally required to have in Massachusetts as a hospital. And we engaged with all of our therapy disciplines. We engaged with our physician colleagues. We engaged with our EMR team. And we engaged sort of across the spectrum. And we, kept an open mind because we heard enthusiasm for this. We also heard frustrations in terms of people duplicating the data that they were collecting and thinking about how we could improve that. And in terms of how we could improve communication among disciplines, whether it be nursing, whether it be social work. And we wanted to balance stakeholder needs in terms of thinking about sort of these 8 ways of lean, in terms of thinking about not doing more data collection just for the sake of data collection, but doing smarter data collection. Okay, so I hope that we've sort of gone over in terms of a little bit about how we at Spaulding have been able to identify different stakeholders to collect patient-centered outcome measures related to health-related social needs and social determinants of health, how we've been able to think about measure quality and suitability, some of the trade-offs to consider, and then also strategies for balancing stakeholder needs. And I think listening is really key, and listening to consumers in addition to the clinical providers, and everyone who is involved in that data collection process, in terms of thinking about having their voice be part of a collective whole. Okay. That's my contact info if you want to reach out. I have lots of screenshots and graphs that I could send you, but I didn't want to bombard you with that. And I also wasn't sure about the technical restrictions on sharing Epic screenshots, but I'm happy to talk and happy to connect. Thank you.
Hey, good morning. I'm happy to bring this on home. So I'm going to tell you a story about what the work we did, and Dave Cones is in here somewhere. Okay, he gets a lot of the credit for the work I'm going to tell you about. He's going to talk later this afternoon about what we got out of this process that I'm going to tell you about. And I'm going to start with, I'm a very pragmatic person. And if I've learned anything working with clinicians, they are really pragmatic. They're busy. So I'm going to tell you about a process that we engaged very busy spine clinicians to select and implement a number of patient-reported outcome measures. So this team treats and manages patients with back and musculoskeletal pain. They do a lot of different interventions, and there are about 20 of them, and they're really, really busy. So this is just a snapshot of the process that it took us, now, don't be alarmed by the number of years it took, because a lot of this was, people are busy. And also, the IT department, I think this is probably true everywhere, they got a lot to do. So it took a while to build things, but I'm really gonna focus on, well, how did we get to pick the things that we wanted to build? So we use Delphi surveys, probably most of you are aware of this, really practical. And it's just the use of usually a series of surveys to get down to voting on something or selecting it. And it's very iterative, it's not linear. And they're quick, so that's why we used it, quick. These people don't have a lot of time. They could do the surveys, which usually took a couple of minutes when they had a moment in their busy schedules to do it. So one of the first things we did was talk about, well, what do we care about actually measuring? And I will say as a preface, this was engaging the clinicians. At some point, we also need to engage the patients. But we were, again, being very pragmatic. We had to get the people doing this work some input on what they wanted to measure. So we asked these 6 topics, and we asked people to rate them on a scale of 1, not important, to 9, very important or extremely important. And you can see the teal bars are where the average fell. So this shouldn't be terribly surprising, but that pain, severity, and interference is very important when you're treating patients with pain, and so on. So once we had some idea of what was important, then we moved to, well, how are we going to measure it? So we did a little bit of preliminary work and met with, in person, this was right before the pandemic. And I will say that probably the pandemic and everybody going remote actually made us go a little bit quicker in the process, because I don't know how quickly we would have pivoted to using surveys had this not happened. So we came up with, in a preface to this discussion and meeting in person, some of the areas based on the topics of interest that we might want to measure, with the intention of talking about it and then starting to come up with, well, what are some of those measures? And I will say, even though these are my colleagues and I've known them for a long time, when we started to talk and they started to say, I care about my patient's quality of life, I care about how they're doing and feeling, that was really eye-opening for me. I shouldn't have been surprised, but I think I expected to have to press that more than I actually did. The clinicians, very busy, but really did care about how their patients were doing in a much broader way than simply their pain and pain severity and interference. So we had a nice discussion. And then I played a role, because of my background in measurement development, in curating some options that the group could consider. Rather than saying, what do you want to use? I gave them a few options to do that. So we came up at the end of this meeting, we came up with these 8 topic areas and connected some measures. And then we began the Delphi process. We created a survey in REDCap. I'm happy to share all these things. I can share the REDCap dictionary, how we did it. And we kept it simple. Thumbs up, thumbs down, yes or no. And then for each of the areas, we offered 2, sometimes 3 options to measure it. We gave the download of the measures so they could see the content. Again, very straightforward. And they also had an option of, you like something better. Almost nobody had an alternative that they wanted. The magic number was greater than 75%. Again, thumbs up, thumbs down. The topic wasn't as much a surprise because we had already conversed about that, but the measure itself. So very straightforward. So should the mechanisms of pain be included? 100% of the group, which is about, I think at this point it was about 20 people, said, yep, it's important. Then we offered Michigan Pain Body Map, Fibromyalgia Score, or neither. These are just the counts. Should these be used? So the fibromyalgia, whoops, I thought I had a little thing. Anyway, Fibromyalgia Score 1, simple majority rule. Pain Detect, that was a no-go. Not many people liked that. So pain mechanism was important. Fibromyalgia score was the way to measure it. Should the patient's perception of change over time be included? And this is really because they do a lot of procedures before or after the procedure. The majority gave it a thumbs up. And they also, this was, I think, the only option, the patient global impression of change scale, 85%, that was the selection. And then when we talked on January 8th, we talked about a lot of these concepts related to health-related quality of life. Again, we were being very pragmatic. We weren't going to ask about every topic. So we talked about using the Promise 29, captures all of these things. 93%, I don't know who the dissenter was, said, yep, these are important. And 86% gave a thumbs up for the Promise 29. So we asked them to just, as a set, is this important? Now, opioid risk assessment, that was not something that ultimately was selected. There was a lot of discussion. So we had a first round of Delphi. You can see only 67% thought that it should be included in the patient-reported outcomes. And so that was not great. And then you can see the two options we gave, not so much. People were not consistent about their desire for this topic. So after we had the round of surveys, we met, had a discussion, still couldn't quite get there, but went for round 2, and basically got nowhere. So that was dropped, and the group thought, if you wanted to do it, you could include it. And I should have said in the beginning, the intention of this is you all have a chance to vote, which means you're all going to do it. And if you choose not to do it, which is actually not in real life what's happening, but most people are, you should be expected to comply. You had your chance. If you didn't take your chance to vote, then you can go along with what the group wanted. So in the end, we have Promise 29 plus 2, which includes a cognitive function, 2 items, global impression of change, and the fibromyalgia score. That took us a few months, but honestly, if you boiled it down, maybe, I don't know, a couple hours of work. Okay, so then we also wanted to know, well, now that we picked them, how are you going to use them? And what do you need to use them in real life? Again, very pragmatic. We wanted to know, first, do you currently use the, and we did this after we had done all this, what I just told you about. Not surprising, the vast majority didn't. And I would say it's not because they don't want to. It's just, well, how do I do it? How do I pick it? And do I have to submit something to IT? Because the culture, and I'm hoping this is changing, at least for our department, is there were no ways to come together and really talk about these things and make these decisions sort of on their own. Some infrastructure is needed, as well as culture to have these conversations. And there was a bit of mix, but the majority felt it was valuable to use these in their clinical practice, particularly for decision-making. Just a bit of a disconnect between picking them and implementing them. We also wanted to know, how confident are you that you can interpret them? There was actually more confidence than I would have guessed that are meaningful, and how comfortable they are in interpreting these in ways that's useful in talking with their patients. So the majority were moderately to very comfortable doing this. So that was good news. And then again, same sort of theme, moderate to quite comfortable in monitoring practice patterns. So getting away or zooming out from just with the patients, but how we doing as a practice. And that I think is, for our group, was an important shift that's probably still ongoing in culture of there are multiple ways to look at how we're doing and communicating with patients. And then the last thing I'll tell you about is that we wanted them, well, now we had selected the measures, we had some sense of their confidence and comfort, knowing we had to do a little bit. And again, Dave gets all the credit for this, is, well, how are we going to help them? And we wanted to know what was going to be the way that was going to help them understand the scores, use them in their practice. So we gave them a couple of options. Somebody teaching them, an instructor-led, a super user that they could contact, and a tip sheet, a guidebook, and so forth. And I think that what won out was the, on the far left, instructor-led. Dave is the instructor, to give them orientation and some help. And then, not surprisingly, a super user. So things that we thought, oh, that's quick, a tip sheet. Well, these weren't so popular. And everybody doesn't have to be the same. That's not the intent of the consensus building. So we wanted to give people some options. So what I'm hoping in this very quick recap of a long process is that this is a proof of concept that can be successfully done in a busy clinical practice with efficiency and rigor. We took the time to, which I'm not going to talk about today, to also revise the intake form, which for some mysterious reason, I don't know if we even know how it even came about, was like this completely inefficient and useless intake form. We used the same process to tear it apart, put it back together again. Again, Dave gets all the credit of, do you want this part? Do you want that part? Do you need it? Do you like it? And so forth. Quite efficiently to totally revise this intake, to ask questions like, what do you want to get out of your treatment? What's important to you? Do you have people to support you, and so forth? So again, widening that lens to include a lot, and a lot of what Chloe was talking about. And so since we've done this process, about 3,000 patients have completed the proms. This is just happening as people are coming to their appointments. So the work at the front end, which I try to say as much as possible, is worth it for the long-term benefit and the return on the investment. And that is it. And you're free to contact me. I'm happy to share all of our all of the stuff that we did, and thank you for listening.